Have you heard terms like precision medicine and personalized medicine and targeted therapies and wonder what this meant? In this video, I will discuss what these terms mean and why these therapies have become so important in the treatment of cancer. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book on cancer called A Short Primer on Why Cancer Still Sucks that can be purchased online through Amazon Books. This is the 7th out of 16 videos that I'm preparing to just present my opinions on some things that people frequently ask me about cancer. For additional details, you can see my book. Importantly, for your own personal health care, you should rely on your personal health care advisors for advice. For cancers, the terms targeted therapy, personalized medicine, and precision medicine generally all mean the same thing, that a therapy has been selected for a patient specifically based on the characteristics of their tumor. And for the rest of this video, I'll be using the term targeted therapy to apply to each of these three types of therapies, which are really the same thing. Cancer cells are highly abnormal, and some of these abnormalities may make them vulnerable to drugs that specifically target that abnormality. For example, a cancer cell may have a mutation of a molecule called the growth factor receptor that is responsible for driving the growth of that cell. In normal cells, that growth factor receptor is turned off unless a signal comes in from the environment that it is important that the cell divide. Then that growth factor receptor is turned on and it will drive the cell to divide. However, in a cancer cell, that growth factor receptor may be mutated, so it is constantly turned on and does not rely on any signal from the environment for it to be turned on. And so it is constantly driving cell growth, even though there's no signal from outside the cell indicating that it is time for it to divide. So our targeted therapy may be designed to block that mutated receptor. And so one group of these targeted therapies are oral drugs that are given by mouth that will target the mutated growth factor receptor. And these targeted therapies that are given by mouth are typically given every day, although sometimes the schedule is a bit different, like they might be given for 3 weeks in a row and a week off, or different things like that, depending on the individual drug. In some patients, these targeted therapies can cause marked tumor shrinkage with marked improvement in symptoms and prolongation of life expectancy. When they do cause tumor shrinkage, sometimes it takes a few weeks after the therapy starts before the tumor begins to shrink. But some patients notice shrinkage of the cancer just within hours of initiating the treatment, with marked reduction in the tumor size and with marked improvement in symptoms that can occur very, very rapidly. So this varies from one person to another and one kind of drug to another. But in some cases, more than 90% of patients will have at least some tumor regression, some tumor shrinkage with improvement in symptoms. If the drug shrinks the cancer, the shrinkage may only last for a very few months in some patients, but it may last for several years in others. And with the shrinkage, not only are symptoms improved, but also life expectancy may be prolonged, sometimes again by 2, 3, 4 years or more. Although in other patients, there may be minimal prolongation of survival, and we are not able to predict how much a therapy will prolong life expectancy in an individual patient. The targeted therapy will also hit normal versions of that molecule, and so this can cause side effects by interfering with the function of some normal cells. Those side effects may be quite severe if the targeted therapy binds to the normal variant of the target or the receptor as tightly as it does to the mutated abnormal one. However, many of these new drugs have been very specifically designed to bind much more tightly to the abnormal mutated version of the receptor than to the normal one. And this can lead to fairly marked benefit against the cancer with relatively few side effects. In addition, if a targeted therapy is found to be of benefit in patients with cancer, this will typically stimulate research so that other groups will try to develop new versions of the drug that are even more effective and less toxic. For example, the early versions of the drugs to target the epidermal receptor growth factor were lorlatinib and gefitinib, and they were very effective with moderate toxicity. And then afatinib came along that was somewhat more effective, but also a little bit more toxic. But then osimertinib came along that is even more effective against many versions of the mutated protein, but also has substantially fewer side effects in the average person. While these targeted therapies can be quite effective at shrinking cancers and improving symptoms and prolonging life expectancy, they do not usually cure cancers. The problem is that long before the cancer was first discovered, there will have been billions of cell divisions. And just by chance, additional mutations will have occurred in at least a few cells that will make the cell resistant to the targeted therapy. And it could be resistant because the drug does not bind as tightly to that one resistant cell, or because an additional growth factor receptor is also mutated. So even if you block the original one, the other one can still drive tumor cell growth. And what happens when we give the targeted therapy, the dominant tumor cell population, the sensitive one, will rapidly die in response to treatment, and so the cancer will shrink. But as that dominant tumor cell population dies, that leaves resistant cells behind that do not die. And when the dominant tumor cell population dies, there's less competition for nutrients and for space for those resistant ones. So they then are able to grow and become the dominant tumor cell population. So initially the tumor shrinks as we kill off sensitive tumor cells, but as the remaining resistant ones begin to grow, then the cancer begins to grow again. And there's a lot of research going on to try to find drugs that will work against those resistant variants. And one example, again, is that with the gefitinib and lorlatinib against the epidermal receptor growth factor receptor, the epidermal growth factor receptor, the new drug osimertinib was developed that is not only more effective, but also, not only less toxic, but also more effective against the resistant variants. So it is more effective overall than the older versions of the drug. We now have several different kinds of oral targeted therapies that work against different targets and that are important in different kinds of cancers, although they are not yet important in all kinds of cancers. Examples of cancers where these can be of value include adenocarcinoma of lung, malignant melanoma, kidney cancer, chronic myelogenous leukemia, gastrointestinal stromal tumors, and a few others. Some targeted therapies also work in a different way. For example, the intravenous drug trastuzumab or Herceptin actually binds to a target on breast cancer cells and also present on the cells of some other kinds of cancer as well, a target called HER2 or ERB2. Cancer cells may have several extra copies of this protein, the HER2 or ERB2. And the usual reason for having several extra copies of it is that there are several additional copies of the gene for that protein in the cell. So something called gene amplification. And if there are several extra copies of the protein on the surface of the cell, that protein may be abnormally driving the cancer cell growth. And if the monoclonal antibody sticks to that protein, then it can kill the cancer cell either by interfering with the function of that overexpressed protein, or by bringing in other components to the immune system to kill that cancer cell. There are also some other types of monoclonal antibodies that hit targets on cells as well. For example, rituximab is important in the treatment of some kinds of lymphomas and leukemias. As with oral targeted therapies, the monoclonal antibodies cannot cure patients, but they can lead to marked improvement in symptoms and prolongation of life expectancy for some patients. A chemotherapy drug may also be attached to the monoclonal antibody. So if a chemotherapy drug is attached to the monoclonal antibody attaches to the tumor cell that overexpresses the target and thereby brings in chemotherapy to that tumor cell, so that the chemotherapy drug is concentrated in the tumor by that action, and so that there's far more chemotherapy in the tumor cells than in normal cells. This attaching of a chemotherapy drug to a monoclonal antibody is referred to as an antibody-drug conjugate. One useful example of this is the drug trastuzumab deruxtecan, where a chemotherapy drug is attached to the monoclonal antibody Herceptin or trastuzumab to bring the chemotherapy drug into tumors that overexpress HER2 or ERB2. There are also examples of attaching radioactive molecules to monoclonal antibodies, so that the monoclonal antibody can then bring the radiation in close to the tumor cell and preferentially kill tumor cells. One of the oldest forms of targeted therapies are actually hormonal therapies, particularly for use in breast cancer. So some breast cancers overexpress receptors for the hormones estrogen and progesterone. And if they do, then those hormones may actually be driving tumor cell growth. Drugs like tamoxifen may bind to the estrogen receptor and block the effects of estrogen on the tumor cell that overexpresses the estrogen receptor. Also, if one reduces the production of estrogen through other mechanisms, that can also lead to shrinkage and control of tumors that overexpress the estrogen or progesterone receptor. In addition to being used to treat large metastatic cancers or advanced metastatic cancers, targeted therapies can also be given as adjuvant treatment. What that means is a patient undergoes surgery to remove a cancer, and then the targeted therapy is given after the surgery is done. The rationale here is that the patient may have millions of small tumor deposits that are too small to show up in the scan, but after the main tumor is removed, then they'll keep on growing and they'll show up as incurable metastatic cancer. But if we give the adjuvant targeted therapy or hormonal therapy, then that may suppress those small metastatic tumor deposits we cannot see, and thereby improve the chance of long-term survival. This is similar to the adjuvant chemotherapy that I discussed in an earlier video. So again, the rationale is to try to suppress the growth or eradicate tumor deposits that are too small to be seen that might show up at a later point in time after the removal of a cancer. In many cases, we do not know whether these adjuvant targeted therapies and hormonal therapies are actually improving cure rates or whether they're just suppressing the metastatic deposits for a prolonged period of time. We'll need several more years of follow-up and experience to really be able to say this with certainty. But we do know that they can be very helpful, very useful in some circumstances. With targeted therapies, as with so many other aspects of cancer care, we are making very useful, very rapid progress. And I expect that things will be much better a few years from now than they are even now. So these are very useful therapies, and I think that they will be even more useful in the future. On this and other aspects of cancer, you can get additional information through my book, A Short Primer on Why Cancer Still Sucks, that can be purchased through Amazon Books if you're interested. I hope that you found this video helpful. Thank you.